to all the respected faculties and my dear colleagues. Today, on behalf of Department of Neurosurgery, I am presenting this CCR. The topic is middle-aged man with right lower limb weakness and foot drop, and following are the collaborating departments. Now coming to the case, we have a 52-year-old male farmer who presented to the neurosurgery OPD in the month of September 2022 with the chief complaints of progressive weakness in the right lower limb below knee since 5 years, difficulty in walking since 3 years, and numbness in the right great toe since 3 years. Coming to the history of presenting illness, the patient was apparently well 5 years back when he developed insidious onset, gradually progressive weakness in the right lower limb below knee joint. The weakness was initially mild, which he kept ignoring for a few months. Thereafter, he tried some alternate medicine, which he got no relief of, and then he consulted a local physician, but he got no improvement. With passing of time, the weakness gradually kept increasing, so much so that he had difficulty in lifting front of his right foot off the ground with dragging of toes and frequent tripping while walking since last 3 years. He had to take high steps to clear his right foot off the ground. He also started noticing that his slipper started to slip off his right foot while walking, and his right foot becoming thinner in comparison to the left leg. He also developed numbness in the right great toe since last 3 years, which was gradually progressive. Coming to the negative history, the patient had no history of low backache, he had no history of radicular or funicular pain, no history of difficulty in turning side to side on bed, no history of difficulty in standing from sitting position, no history of bladder bowel dysfunction, no history of fever, night sweats and cough, no history of headache, vomiting or seizure episodes, no history of significant weight loss, no history of waxing and waning coats, no history of trauma in any form, or no history of lumbar puncture. The past history was not significant. The family history was not contributory. He was married, having 2 children, non-addicted, vegetarian by diet with normal blood and bowel habits and normal sleep pattern. Drug history was not significant. He had no history of any allergy to any drugs. He took some medications from local physician but discontinued after some time. Now, based on the clinical history, I would like to know from the audience that what could be the likely diagnosis.
But before that, for the sake of especially neuro residents and us, if you can go back to the negative history and explain to us what is the relevance of asking those questions. Would you like to discuss the differential first and then come to this? Because you may reveal the diagnosis while discussing this. Yeah. So, neurology and neurosurgery residents?
And medicine.
Oh, yeah, medicine. And I hope all the residents noticed how detailed the history was to highlight the foot drop. Can any resident tell me what kind of a gait you would expect before he goes on to examination in a patient who has a foot drop? What is it called, if I remember correctly?
High stepping gait.
Sorry?
High stepping gait.
Yeah. Is this stomping gait?
No, sir. It's
No.
the high stepping
High
gait
stepping.
or a steppage gait.
Okay. So now Dr. Sherpa's question. Can you please continue? What is the likely diagnosis? Dr. Munish, I think we need to do that. We need to reserve those seats for the residents so that we know that who is to be addressed. Yes, please. Whichever. Then we will have to turn our head every time.
So medicine के residents कौन है? Any third years from Department of Medicine?
कोई रेजिडेंट है क्या? मेडिसिन सर?
तो डॉक्टर पुनीत भी नहीं है.
Neuro or neurosurgery?
Investigations to that.
Symptoms are mostly pertaining to the lower limb and also on particular injury. So first we put our differential diagnosis as some compression to the nerve roots, either
Standing slowly progressive lesion, right? Number 2, it is a lower motor neuron lesion. You can make that assumption because there is wasting of the limb. So what will you think when you have?
So based on the history, we know that this patient has presented with isolated foot drop. And the following are the causes which can cause foot drop. It can be traumatic. In the trauma, it can be injury to the dorsiflexus, tendon injury, or it could be a nerve injury. So nerve injury can be either at the level of common peroneal nerve, that is local, and or either it can be above the common peroneal nerve, which can be either injury to the sciatic nerve, or it can be a spinal cord injury, or even a disc prolapse compressing the nerve roots. In the neoplastic causes, it can be due to spinal tumors, which can be benign as well as malignant. And it can also be some due to cortical lesions, mainly located in the motor strip region. It can be due to medical causes such as motor neuron diseases, including amyotrophic lateral sclerosis, hereditary causes, Charcot-Marie tooth disease, and spinal muscular atrophy, and iatrogenic causes. We can induce a foot drop in the patients, such as in cases surgery of lumbosacral spine, hip and knee surgery, and in patients who have undergone cast applications, such as in orthopedic cases. Infective etiologies includes leprosy, poliomyelitis, Guillain-Barré syndrome, or metabolic causes such as diabetic neuropathy or vitamin B12 deficiency, leading to subacute combined degeneration of core. And it can also be due to exogenous toxins.
Now, could you please go back to the negative history slide and explain?
We should have discussed localization more rather than etiology. This region could be here, here. With your findings, where you think that the localization is very important. The neurology is most important is localization.
Now coming to the
This patient could have paracetamol mania.
now, as sir has asked about the negative history, how to rule it out. This is just on the basis of history that patient has no low backache. In any spinal lesions, such as some tumor or some compressive pathology, including the extradural causes, patient can have a low backache, or a disc prolapse, patient can have low backache, or in case of trauma. The radicular pain is usually seen when there is a discogenic pain, or when the nerve is compressed by the disc prolapse. And the funicular pain is a vague pain, poorly localized referred pain, which is non-localizable. And from the history of difficulty, there was no history of difficulty in turning side to side. I mean to say it's kind of localizing, because the abdominal muscles are intact. So we could say that below, at least the patient has his neurological findings are normal till the level of abdomen. And similarly, no history of difficulty in standing from sitting position, which implies that there is no proximal muscle weakness or the hip muscle weakness. And the bladder wall involvement, as we know, it's an autonomic function, so there is no autonomic system involvement. History of fever, night sweats and cough. In case of infective etiology, it could be even a tuberculosis. Here in the negative history of headache, vomiting or seizure episodes, it could be a intracranial pathology which could lead to raised ICP and leading to headache, vomiting or seizure episodes. The history of significant weight loss, we know, is a constitutional symptom of a malignancy. And the history of waxing and waning is usually seen in motor neuron disease, the multiple sclerosis. So rest is clear.
Can you talk about lumbar puncture? What about the injection in the gluteal region? Is there any?
No. There is no history of any injection or any form of trauma to the patient. Now coming to the general physical examination, the patient was conscious, cooperative and well oriented to time, and the vitals, including temperature, pulse and BP, was essentially normal. The systemic examination, including the respiratory system, cardiovascular system and per abdomen examination, was essentially normal. Now coming to the central nervous system examination, the high mental functions were normal, speech, cranial nerves were normal, There were no signs, cerebral signs, no signs of meningeal irritation. And on examination of the spine, there was no deformity or no local tenderness. Coming to the motor examination of both the upper limbs was essentially normal. In the lower limb examination, there was reduced in the muscle bulk in the right lower limb, mainly the mid calf. It was 20 centimeters in girth, and the left lower limb had 24 centimeters in comparison. The tone was decreased at the ankle region. And in the powers, the hip and knee had a normal power on both the sides, but in the ankle dorsiflexion, the power was 0/5. And in the eversion was also, ankle eversion was also 0/5, and inversion was 1/5. The extensor hallucis longus, it was 0/5. The deep tendon reflexes in both the upper and lower limbs was essentially normal. The superficial reflexes, including abdominal reflex, cremasteric, and Babinski reflex, was normal. Normal.
So what is the power of tibialis anterior and tibialis posterior?
Tibialis posterior, it was tibialis posterior is 1/5 because it causes inversion. So tibialis anterior, it was 0/5 because tibialis posterior was 1/5. Now coming to the sensory examination, the patient had decreased sensation to light touch, pressure, pain and temperature over the right great toe, dorsum of right foot, and the anterolateral aspect of right leg. However, the fine touch, two-point discrimination, vibration and proprioceptions were normal. The coordination was normal, but this patient had a high stepping gait on the right side. There is a representative diagram image on the right side where the patient is having a high stepping gait. You can see he is abnormally raising his, there's increased flexion of the hip and knee to clear his foot off the ground. We have performed some special tests like straight leg raising test, which was negative. This test is performed to rule out any discogenic pain where the knee, where the leg is extended, raised. With the patient in supine position, the leg is raised with the knee in extension. If the patient feels pain in between 30 to 70 degrees, we usually consider that the SLR is positive and it is likely due to some discogenic cause. Whereas this is Faber's test, bilateral lower limbs. Faber means flexion, abduction, and external rotation of external rotation. This test is done to rule out any hip pathology or a sacroiliac joint pathology. Here, the examiner keeps one with patient knee in flexed position. The foot is placed over the contralateral knee, and one hand presses the knee, and the other hand is kept over the hip joint. With simultaneous compression on both the hands, patient can feel pain if he has some hip or SI joint pathology. This is a Rombox test, which is done to rule out to differentiate between the cerebellar ataxia or the sensory ataxia. This test is performed with the patient in standing position with the heels close together, patient with the eyes open and then eyes closed. Here the inference is if the patient has excessive swaying or loss of imbalance with the eyes closed as well as eyes open, this means that patient has cerebellar ataxia. Whereas if the patient has only swaying or loss of imbalance when his eyes is closed, then it implies that he has a sensory ataxia, it's proprioceptive ataxia. Now let's review our patient. We have a 52-year-old male presented with difficulty in walking due to dragging of right foot, numbness in the right great toe region extending to the dorsum of foot and anterolateral aspect of right leg. Isolated right lower limb weakness, no backache or radicular pain, no history of trauma. On examination, there is wasting of right leg muscle, mainly the anterior compartment. There is a motor weakness of right foot and decreased sensation at L5 dermatome on right side, and no bladder and bowel involvement. Now, on the basis of history and clinical presentation, I would like to ask the audience what is the likely diagnosis and the anatomical level. Now, since we are assuming it to be a spinal pathology, I would like to briefly describe the anatomy so that there is clear understanding. Here we can see a diagrammatic representation. This is the vertebral body, this is the lamina, and this is the spinal cord. You can see this is the epidural space, this is dura mater, the pink one is arachnoid mater, and the yellow one is pia mater, closely related to the spinal cord. So we have epidural space, subdural space, and subarachnoid
This
space.
you tell later on once you have time. But you this you are showing in the upper level, dorsal level.
Yes.
Usually it is in the lumbar. What is your diagnosis? You have not told here. You have asked him,
Sir.
but what is your diagnosis?
Yeah, the full neurological diagnosis.
Diagnosis we
मैं तो ये सब बात नहीं बता
Based on this history and examination, what is the clinical diagnosis? Which may not be correct.
Correct.
The investigation may show it to be something else. But if you see this patient in the OPD, what will be your clinical diagnosis, number one, number two, number three? That is what.
based on the history and clinical examination, the likely diagnosis is the lesion is within the spinal cord. We suspect to be a lesion in the spinal cord, compressing mainly the L5 nerve root.
Spinal cord ends at elbow.
No. Yes.
So where will come the spinal cord?
Would you consider spinal pathology, and which pathology without any history of backache and no radicular pain?
Yes. This case was a little unusual, sir.
So your diagnosis may be wrong. Everybody can't make diagnosis.
See, this is another reason that students in the exam should not try to know the diagnosis. Once you know the diagnosis, your thought process gets biased. Now, I'm sure he knows the diagnosis, and that is why it is difficult for him to give a clinical diagnosis, because he knows that clinical diagnosis is going to be wrong.
I say it's parasagittal meningioma. Who will be wrong?
Parasagittal meningioma, sir, based on the history, he had no history of any
No, say nahi, positive.
positive.
He has foot drop. Foot drop is a presenting symptom or sign of a parasagittal meningioma.
So is sensory involvement common?
Sir, in that case, in the history we have given that there is no sensory motor symptom other than headache and seizure.
Motor.
See again, anything. Seizures may not be there, headache may not be there, but still he could have parasagittal. So negative things say nahi hai. So you have to consider this diagnosis still hai. If you get a MRI and you see that there is nothing. So that's the way to exclude. So,
Can it be a non-surgical cause, say like mononeuritis?
Yes, sir, it could be. It could be even.
There are lots of causes of mononeuritis, so that also has to be checked.
I think we can proceed.
Yeah, proceed.
Yeah, please.
Said whatever way you have prepared.
Sir. So I was describing about the clinical features in the patient with extramedullary and intramedullary lesions. Extramedullary means lesion outside the spinal cord, and intramedullary means the lesion inside the spinal cord. Here we can see the extradural lesion which is compressing upon the, it is in the epidural space and compressing the whole dura including the spinal cord. This is the sagittal image of the same. This is the intramedullary, extramedullary, where the tumor is located inside the in the arachnoid space, but compressing the outside the spinal cord. And this is the intramedullary, where the lesion is located inside the spinal cord. So these are the clinical features of extramedullary and intramedullary spinal cord lesions, where in the history, the extramedullary lesions usually have a asymmetrical, slow and progressive onset, which our patient had also the similar finding. In the motor neuron examination, the upper motor neuron signs is common and early in extramedullary but late. In the lower motor neuron signs, there is usually segmental involvement in the extramedullary lesion, whereas there is diffuse involvement in the intramedullary. There is usually root pain associated with extramedullary lesion and funicular pain in intramedullary. Dissociated sensory loss is absent in the extramedullary lesion, which is same case with our case, but is present in the intramedullary. The sacral sensation is spared, which is unusual in our case. Our patient had a spared sacral sensation, and the bladder and bowel involvement is late in extramedullary. This are few common tumors, common lesions of the spinal cord, which the extradural lesions, intradural and extramedullary. The metastasis is most common in the extradural pathology. Second, ball spine, disc prolapse, chordoma. The list is long, but I have included some common ones. And the cystic lesion, including the arachnoid space, is usually not very common. Now coming to the lab investigations, were all normal. And I would like to invite Dr. Nahid Yasmin, Associate Professor, Department of Anatomy, to further elaborate the spinal cord anatomy.
Thank you, Dr. Shireen. To better understand the case, now we will see the anatomy of spinal cord. Spinal cord is the lower elongated part of central nervous system. It is the downward continuation of medulla oblongata, which extends from the upper border of posterior arch of first cervical vertebrae to the lower border of first lumbar vertebrae. It occupies the upper two-thirds of the vertebral column. It will connect the body and the brain through various ascending and descending tracts, as well as it executes reflex actions. The spinal cord is covered by three protective membranes called the spinal meninges. From outside to inside, these are the dura mater, the arachnoid mater, and the pia mater. Dura mater is very tough, opaque, inelastic membrane of fibrous tissue which extend up to the lower border of second sacral vertebrae. Inside it lies the arachnoid mater. This is the arachnoid mater. It is thin, delicate, avascular membrane that loosely invests the spinal cord, and it also extends up to the lower border of second sacral vertebrae. The innermost layer is the pia mater. It is thin, transparent, highly vascular membrane that closely invests the spinal cord. Below the lower end of the spinal cord, the pia mater extends as a thin thread-like filament known as filum terminale, which extend up to the first coccyx vertebrae. In between these meningeal layers, there are few spaces that surround the spinal cord. The first is the extraepidural space, which lies between the vertebral canal and the dura mater. It contains loose areolar tissues, small arteries, network of internal vertebral venous plexus, and the spinal nerve root. This is a space which is mostly used for the giving epidural anesthesia to block the pain in a particular region of our body, especially for different gynecological surgeries, cesarean section, and the surgeries of lower limb. Then the subdural space, which is a space between the dura mater and the arachnoid mater. This is the subdural space. It is filled by the thin capillary layer of fluid. The inner layer space is the subarachnoid space. So this is the subarachnoid space which lies between the arachnoid and the pia mater. It is filled with CSF. Below the lower end of the spinal cord, in the lower part of the vertebral column, the subarachnoid space becomes roomy, forming a pool of CSF called the lumbar cistern. And the interspinal space between the third and the fourth lumbar vertebrae is the most preferred site for lumbar puncture, as in this region the subarachnoid space is roomy, and this lumbar puncture is done to collect the cerebrospinal fluid for various therapeutic and diagnostic purposes. Now we will see the external features of the spinal cord. The spinal cord is relatively cylindrical in shape, which is flattened antero-posteriorly. Each half of the spinal cord is divided into two symmetrical halves by the anteromedian fissure and the posterolateral sulcus. Each half provides attachment to the rootlets of the ventral rootlets of the spinal nerve as well as dorsal rootlet of the spinal nerve. These two rootlets joins to form the spinal nerve. Thus, the spinal cord provides attachment to 31 pair of spinal nerves, and the part of the spinal nerve which provide attachment to a pair of spinal nerve is known as spinal segment, and hence the spinal cord has got 31 spinal segments. As the length of the spinal cord is smaller than that of the vertebral column, the spinal segment and the vertebral level does not correspond, and as such the lower spinal segments are shorter and crowded. There is a general rule that the upper cervical spinal segment lies at the same vertebral level, whereas the lower cervical segment cervical spinal segment lies one vertebrae higher. The upper thoracic lies two vertebrae level higher, whereas the lower thoracic spinal segment lies three vertebrae level higher. Whereas in the lumbar region, it lies approx 3 to 5 vertebrae level higher, and in sacral and coccyx, it lies approx 6 to 10 vertebrae level above. Thus, the upper spinal nerves runs horizontally to pass through the corresponding intervertebral foramen, whereas the lower spinal nerves runs downward and obliquely to pass through the corresponding intervertebral foramen. Thus, below the lower end of the spinal cord, the lower 4 pair of lumbar spinal nerve, the 5 pair of sacral spinal nerves, and the 1 pair of coccyx nerve form a horse tail like structure called the cauda equina. So this is the cauda equina. When we will see the cross section of spinal cord, the spinal cord consists of an inner zone of grey matter, which is edge or butterfly shaped, and it consists of neuronal cell bodies, the nerve fibers and their processes, the nuclei and the blood vessels. The outer zone is the peripheral white matter which contains the nerve fibers. The collection of the nerve fiber is known as tract. Thus, and a central canal which is filled with the cerebrospinal fluid. Thus, in the white matter, there are presence of numerous ascending or the sensory tract, whereas descending or the motor tract, the important one being the lateral spinal thalamic tract, which will carry the pain and temperature sensation from the opposite side of the body. The anterior spinothalamic tract, which will carry the crude touch and pressure sensation from the opposite side of the body. This is the lateral column tract, that is the tract of Gall and Burdick, which will carry the fine touch, two-point discrimination, stregnosis, joint sense, conscious kinesthesia from opposite side of the body. The important descending tract is the lateral corticospinal tract, which will control the rapid voluntary movement, skill voluntary movement of our body. Thank you. Now I would like to call Dr. Harish Meena from Resident Department of Radiodiagnosis.
Good morning, everyone. I will be discussing the MRI finding of this case. The scan was done outside. These are the sagittal sections of the dorsal spine, and these two are the T2 weighted images, these two are the T1 weighted pre-contrast images, and these two are the T1 weighted post-contrast images. In the T2 weighted images, we can see that there is a near CSF intensity lesion at the level of extending from D11 to L2, and it is also scalloping the bony margins posteriorly. And as we can see, this black line right here is the dura, and the dura is not encompassing the lesion, thus we can say that it's extradural in origin. And with a slight herniation at the level of L4, L5 level. And in the T1, we can see that the lesion was iso-intense, so we can say that there was no fat component. And in the post-contrast image, we can see again there was no enhancement, thus ruling out any solid component. In this axial section at the level of D12L1, we can see that the lesion was lobulated and was compressing the thecal sac and the quadratic minor nerve roots. At this section at slightly lower level, L1, L2, we can see that the lesion is slightly extending towards the left neural foramina. This section at D11 level was taken through the conus, and we can see that there is hyperintensity at the right half of the conus with slight volume loss, representing a case of myelomalacia. At this L4, L5 level, we can see that there is disc herniation at the paracentral disc herniation, and it's slightly impinging the traversing right nerve roots. But in our radiological opinion, the compression was not significant enough to cause a foot drop in this patient. These are the coronal section of the. We can see that the lesion is lobulated and it has ill-defined margins. After reviewing all the scans, we came up with 4 differentials, which were arachnoid cyst of extradural origin, spinal epidermoid cyst, ligamentum flavum cyst, and dermoid cyst. We were able to rule out dermoid cyst because dermoid cysts have a fat component, and fat is usually hyperintense on both T1 and T2 weighted images, but as I showed you earlier, there was no hyperintensity in the T1 weighted images. Ligamentum flavum cysts are usually very small, and this lesion was significantly very large. Spinal epidermoid cysts are visually very similar to arachnoid cysts, but they are usually acquired in nature and have a spinal malformation associated with them, like spinal bifida or hemivertebrae, which was not present in this case. So our final diagnosis was arachnoid cyst of extradural origin. Thank you. Now I would like to call Dr. Schering to discuss the case.
How you are going to differentiate between the myelomalacia and what edema?
Because the history is like...
Not radiology.
But first you mentioned the volume loss is there, and secondly it is nearly isolated to CSF, so probably it is a myelomalacia.
Don't you want to compare with the T1 weighted image?
To see both T1, T2.
So we didn't have T1 weighted
You
image.
have to. My question is straightforward.
So it was
As a
hypointensive
radiology.
T1. It was there, it was hypointensive T1.
So it was hypointense on T1, so then it is myelomalacia. Okay?
Now, on the basis of history, clinical examination and radiological evidence, our provisional diagnosis was spinal extradural cystic space occupying lesion extending from D11 to L2 level. With the working diagnosis, same, spinal extradural cystic as well, D11 to L2, with cord compression. Surgery was planned, and after taking due consent, surgery was undertaken. Now I will request Dr. Yogesh Agrawal, Associate Professor, Neurosurgery to...
Thank you. Good morning, everyone. Now we will discuss the operative management of this patient. So, treatment vary according to the symptomatology of the patient, and if in these cases patient is asymptomatic, then conservative management with repetitive and MRI in follow is sufficient. And in symptomatic patient with any neurological deficit, these are the ways to treat. First is the CT guided or MRI guided percutaneous chest puncture, but there is a more chance to recurrence in this method. Another is the implantation of a shunt, in which we put a shunt between the cyst and the subarachnoid space, but here is also the chances of recurrence are there. Another is the fenestration of cystic wall. In this case, we do the fenestration by laminectomy and rupture of the cystic wall or aspiration of the cystic wall and the clipping of the dura. But the precise pre-operative planning is must in these cases to locate the exact site of dural tear. And now the next method, that is the complete microsurgical rejection, and it is the gold standard and the treatment of choice in these cases. So, indication of surgery in this cases is progressive neurological deficit affecting day-to-day life of the patient. And what are our objectives? Our objectives first is the decompression of cord and bilateral nerve roots, closure of the dural tear and the communicating ligation of the pedicle and the watertight repair of the dura, and if there is any nerve root inside that cystic herniation, then replacement of that nerve root, and the restoration of the normal function and anatomy, and if at all instability is there, then the fixation is also required. So what we did in this case, we did D11 to L2 laminectomy with complete excision of lesion and watertight. So what we did, D11 to L2 laminectomy and the watertight closure of the dura and ligation of the pedicle. So what we do in the laminectomy, this part of the vertebra, spine of the vertebra, we remove along with the small part of the bilateral lamina. So in these cases, if the in preoperative period or in the MRI we don't exactly locate the site of the dural communication, then we have to expose whole of the lesion by the multiple level laminectomy. Now we can see in this picture, we expose whole of the lesion extending from that, this is the normal D10 vertebrae and this is normal L3 vertebrae. So we did laminectomy of the D11 to L2 and exposed completely this lesion. And this is left side, this is right side, this is cranial end and this is caudal end. This is intraoperative video of that same patient. Whole of the lesion we exposed, and these are the whole extent of the lesion. This is now we are separating the lesion from the underlying dura, and there are many adhesions there. So we broken the adhesions and gradually and gently we separated the lesion from the underlying structures. Here we can see that gradually we are separating this lesion, and it is a cystic lesion filled with the watery fluid, likely CSF. Here in this video we have completely separated the lesion and excised completely. Here we can see that the gush of the CSF coming from the this lesion here, this one. CSF is coming out from the lesion. So complete lesion we excised, and we repaired the small tiny dural defect that was present on the posterior lateral aspect of the this port, and packed with the fat and Surgicel. This is post-operative, this is the picture when we have removed the whole of the lesion, and this is the site where we repaired the dural communication and close the watertight, close the dura and place a fat patch and Surgicel. This was the specimen which we have sent for biopsy, histopathological examination. Thank you. Now I invite Dr. Sonam Arya for pathological.
Good morning everyone. Now I'd like to explain the pathological aspect of the case. So we received a raw specimen of a single cyst measuring 7 into 2.5 centimeter. Its external surface is grey-white and unremarkable, and cut surface is grey-white. So on microscopy, a cyst wall formed of delicate fibrous connective tissue lined variably by meningothelial cell was seen. We see on scanner low power and high power. On scanner and low power, we clearly see the cyst wall, and on high power, we see the fibrous connective tissue variably lined by meningothelial cells. So the histopathological features are suggestive of arachnoid cyst. These are the DDs of spinal meningeal cyst. They could be extradural cyst or intradural cyst. The cystic spinal lesions result from a number of disease entities. They could be primary or acquired. So our most common differential diagnoses are these 5 DDs, that is neuroenteric cyst, meningocele or meningomyocele, epidermoid cyst, dermoid cyst and arachnoid cyst, and we can differentiate them on microscopy by H&E staining. So our diagnosis is arachnoid cyst. Spinal cyst in last 5 years in our institution. There are 5 cases of neuroenteric cyst were reported, 5 cases of meningocele or myelomeningocele, 11 cases of epidermoid cyst, 12 cases of dermoid cyst, and 12 cases of arachnoid cyst were reported. Thank you. Now I'd like to call Dr. Sharing for further cases.
I would like to cover the follow-up. The patient was, the post-operative period was uneventful, and the patient was discharged in the post-operative service. During the discharge, his power in the dorsiflexus was 1/5. Physiotherapy was started post-operatively. Patient was kept on monthly follow-up, on 3 months follow-up with rigorous physiotherapy and rehabilitation. He had an improved power of 3/5. On 6 months follow-up, patient can walk independently without support, and his gait has also improved. Bulk in the right leg muscle has improved. The sensory symptoms are improving. Now I would like to invite Dr. Harshita to cover the physiotherapy aspect.
Good morning everyone. Now we will discuss about the physiotherapy part. So our goals were to increase muscle strength of the foot muscles, to improve functional mobility, and to reduce risk of falling. So as we know that physiotherapy is a graded protocol, so we had started with the passive range of motion exercises of the toes, like flexion and extension, and for foot we had started with dorsiflexion, inversion and eversion, followed by the active assisted range of motion exercises. After that, isometrics of tibialis anterior muscles were started, and stretching of calf muscles were given to prevent shortening of the muscles. So these are the videos of passive range of motion exercises, followed up by the active assisted range of motion exercises with knee slightly in flexion. So muscle stimulation were given. Muscle stimulation was basically given by 2 types, like Faradic and galvanic currents. So Faradic current is used in case of innervated muscles, and galvanic is used in case of denervated muscles. In this case, we had used interrupted galvanic current, and one electrode was placed on the nerve root, and the other electrode was placed on the muscle belly, like on the motor point. And we can see the stimulation in the toes after applying the stimulations. Roots technique were used for facilitation of the muscles, like tactile stimulations were used. In this, fast brushing and stroking were given to the low threshold receptors. Then quick light stretches were given, and tapping over the muscle belly was given to facilitate the muscle path. These are the strokings which we had given to the patient. Kinesio tape was used. Kinesio tape is basically an elastic tape which we give to facilitate dorsiflexion of the foot for the biomechanical correction and to improve the walking pattern. And we can see that after applying the kinesio tape, the walking pattern of the patient gradually improved. Gait training was started with the help of parallel bars, and balance and posture exercises are also started along with it.
foot drop splint was given to the patient to provide dorsiflexion, as after exercises also some kind of support was needed, so that's why. Now I would call Dr. Sharing to...
So since this was a rare case, I'll briefly go through the review of literature. This is a very rare case which approximately seen in 1% of the spinal tumors, generally in the men, and third to fifth decade. The most common it is seen in the 2/3 of cases, it is seen in lower thoracic region. It is basically an outwatching herniation and through the small defect in the dura. Etiology is still unknown. It is suspected to be congenital in origin. However, acquired cases, it could also be acquired. Here we can see in this diagram that there is a small defect in the dura with the small outwatching of the subarachnoid layer. And with gradual increase in the intraspinal pressure, there is an increase in the CSF outwatching. With subsequently, when it becomes large, it causes a valve defect and compresses the cord. So the take-home message is spinal epidural arachnoids. This is a very rare condition. Presentation is not always a textbook-like, and thorough clinical evaluation is must. Early and timely surgical intervention will prevent development of severe morbidity, and it is of utmost importance for the multi-specialty team to work together for the diagnosis management, and the physiotherapy is vital. Now, on behalf of Department of Neurosurgery, I would like to take this opportunity to express my thankfulness and deep gratitude to all the collaborating departments for their kind cooperation. A special mention and thanks to the CCR Reviewing Committee for their constant guidance and support. Thank you.